Good morning, Jennifer Carvey, Legislative Counsel, and I believe I am convening this meeting of the Health Reform Oversight Committee. Today is Thursday, November 30th, and we will begin with the election of the chair of the committee. So to start, I would entertain nominations.
I nominate Senator Lyons to be chair.
Okay. Senator Lyons has been nominated. Are there any other nominations? Hearing none, close nominations and take a vote. All those in favor of electing Senator Lyons as chair of the Health Reform Oversight Committee, please raise your hand. All right. All those opposed? All right. Madam Chair, turn it over to you.
Thanks, Jen. Thanks very much. And thank you all for being here this morning. Before we go any further, I'd like to entertain nominations for vice chair. And with that interest, unless there's another, I would
nominate Representative Lori Houghton as vice chair.
Thank you, Representative Wood. Are there any other nominations? All right, nominations are closed. All of those in favor of Representative Houghton as vice chair for HROC, please raise your hand, say aye. 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 All right, thank you. And Senator Kitchell, thank you for being with us here remotely, and we hope that that heals rapidly.
Well, I didn't want to overutilize healthcare, so I went 2 weeks with a broken wrist.
Okay, that's a good place to begin. You know, why don't we just go around and introduce ourselves? There are a lot of folks here and then also out on Zoom, and it would be helpful just to know who's here around the table for HROC, and we'll start over here. Yes.
Senator Ann Cummings, I chair finance in the Senate.
Representative Diane Lamper, and I chair the House Appropriations Committee.
Senator Jenny Lyons, chair Health and Welfare.
And Representative Lori Houghton, I chair House Healthcare.
Representative Teresa Wood, and I chair House Human Services.
Representative Emily Kornheiser, and I chair Ways and Means.
And I'm Senator Rich Westman, and I don't chair any.
Don't let that fool you.
And go ahead, Senator Kitchell.
Senator Jane Kitchell, chair of Senate Appropriations. I wish I could join you today in person, but I'll be there tomorrow because Scott Beck is going to chauffeur me.
All right. Well, thank you, Scott, for doing that. We're sorry you're not here, and certainly we'll have an opportunity for questions as we go through and after each presentation. So we'll look for you to raise your hand when it's time. We'll say before we begin, this is a real opportunity for us to look at where we are with Act 167. There was language, and I think Jen will go through it with us in just a minute, for an update on some of the work that's going on outside of the building as a result of the legislation. The legislation itself is a culmination of a lot of work that we have done over time to integrate our social services with our medical services and to improve our continuity of care for patients overall, while keeping an eye on improved quality as well as lowering the growth of costs in the state. So we each have worked hard on this. The work that is being done, as we'll hear, has implications not just for policy and improvements in the system itself, but also for looking at the financial issues around healthcare. And that is why this committee is so appropriate in terms of having policy wonks as well as financial wizards. And I really appreciate the time that all of you who are here with us have taken to be here, and as well to help us through as we go through the next session. This is the beginning, and I'm going to turn it over to Jen in just a minute, but I just would like all of us here at the table to understand that we are going to be listening today. This is an opportunity to hear what's happened, what's going on, for us to get somewhat of a start before the session begins, And then as our committees dive further into the issues, we'll have some background to go forward. So with that in mind, as we hear from folks, I'm going to ask that we hold all of our questions until after each person has presented. I know there are 1,000 questions. There's no doubt about that. And there's a lot of interest. And I think that we'll have an opportunity to ask those questions, if not all today, as we go into the session. Vice Chair, did you want to add?
I just want to add one thing. I think it'll become clear as we hear the presentations. There's been an awful lot of work by many people in this room over the summer on what we're doing in health reform. And so just a big thank you to everyone who has spent countless hours in meetings this summer and this fall to get us to this point. And as Senator Lyons said, this is just the beginning for us in this building. There'll be a lot more work to do through the session.
Thank you for that. Good. All right. So let's get started. We're here. We'll take a lunch break and then we'll be back afterwards. So we'll take our break at 12:30. So we have a long day ahead of us and we'll finish hopefully by 3 o'clock. Good. So Jen, thank you.
Yes, I thought it might be helpful to start. I think you're going to be hearing a lot today about some developments that are coming out of the work you did on Act 167 from 2022. So it seemed like it would be a good idea to review briefly what that act did. So this is Act 167. As you may recall, this was an act relating to healthcare reform initiatives, data collection, and access to home and community-based services. And we're looking specifically at sections 1 and 2 under the payment and delivery system reform. Section 1 had directed the Director of Healthcare Reform in the Agency of Human Services, in collaboration with the Green Mountain Care Board, to develop a proposal for a subsequent agreement with the federal government to secure Medicare's continued participation in Vermont's multi-payer alternative payment models. In developing the proposal, the director was to consider the total cost of care targets, global payment models, strategies and investments to strengthen access to certain types of care, strategies and investments to address health inequities and social determinants of health, and the role, if any, that accountable care organizations should play in Vermont's multi-payer alternative payment models going forward. There are a lot of considerations included in the language here, and I just think it's helpful to have that frame of reference when you start to hear testimony about how these are playing out. So the development of the proposal must include consideration of alternative payment and delivery system approaches for hospital services and different types of community-based providers. The alternative payment models to be explored had to include at least value-based payments for hospitals, including global payments, statewide, regional, and hospital-based global budgets for healthcare services, or a combination of them, existing federal value-based payment models, and broader total cost of care and risk-sharing models to address patient migration patterns. The proposal had to must include appropriate mechanisms for converting fee-for-service reimbursements to predictable payments for lots of provider types, include a process to ensure reasonable and adequate rates of payment and a schedule for rate updates, meaningfully impact health equity and address inequities, and support equal access to appropriate mental health care as part of the integrated healthcare system. Other directives to the Director of Healthcare Reform: make sure that the development process includes opportunities for meaningful participation by all stakeholders. The director must provide a simple and straightforward process so that stakeholders can provide input, and it allows the use of existing local and regional forums. So that was all directed specifically to the Director of Healthcare Reform in collaboration with the Green Mountain Care Board. Next, we have a directive to the Green Mountain Care Board, and in this case, to collaborate with the Agency of Human Services, and using that same stakeholder process, build on successful healthcare delivery system reform efforts by developing value-based payments, including global payments, from all payers to Vermont hospitals or ACOs or both, that will help move the hospitals away from a fee-for-service model, provide them with predictable, sustainable funding that is aligned across multiple payers, consistent with the principles for healthcare reform, and sufficient to enable them to deliver high-quality, affordable healthcare services to patients. Take into consideration the necessary costs and operating expenses of hospital services, and take into consideration the rural nature of the state. Also determine how best to incorporate value-based payments, including global payments, into the board's regulatory processes. Recommend a methodology for determining the allowable rate of growth in hospital budgets, which might include the use of certain benchmarks. Consider the appropriate role of global budgets for Vermont hospitals. And there was a progress report and an update required in January and March of this year. I think you'll be hearing more about how those are going today. That was all in section 1. Section 2, we'll probably spend a little less time on the details of, but this was the Green Mountain Care Board's, again, in collaboration with the Director of Healthcare Reform, but process for developing an engagement process for Vermont's hospitals to reduce inefficiencies, lower costs, improve population health outcomes, reduce health inequities, and increase access to essential services while maintaining sufficient capacity for emergency management. It goes into details about the engagement process. It must be coordinated with the Director of Healthcare Reform's engagement process from section 1, include hearing from and sharing information with communities about the current and future states of the hospital delivery system, unmet healthcare needs, and opportunities and resources for meeting those needs. Thank you. Must provide opportunities for meaningful participation in all stages by various stakeholders. Provide the data, information, and analysis necessary to support the engagement process, including information and trends relating to the healthcare delivery system in each hospital service area and other impacts on the hospital system, hospital services, and other providers. Establish ways to assess the impact of any changes to hospital services on non-hospital providers, looking here specifically at workforce recruitment and retention, and then figuring out how much in the way of resources would be needed to support the hospitals to make the transformation initiatives. Again, there was an update required in January of this year. So that is a reminder of everything in those two sections to frame your conversation today.
Thank you.
Yes.
That was thorough. I'm sure we'll be back looking at the details of that again, but thank you very much, Jim. So within the budget, there was a request for the Green Mountain Care Board to give us an update by November 1st on the work that was being done in the bill, section 2. And so we have, Foster is here. So why don't you come up and, you want to bring everyone up?
Also, do we need chairs down there?
I think for this section, with your permission, it'd just be personnel and myself.
Okay, so just pull another chair over. Someone can help.
Yeah, there's a chair here.
Is there a chair over here?
Take mine and I'll put that.
So, and just to follow up on Representative Houghton's comment about all the work that's been going on in the summer, a lot of community engagement has been going on, both within by the board and also by the agency of Human Services. And the feedback that at least I've been getting is how really exceptionally well done it's been done. So thank you for your work. Now we're listening.
Great. Well, first, thank you to the chair and vice chair for inviting us to the committee, for having us here to provide this update. And most of you, my name is Owen Foster. I'm the chair of the Green Mountain Care Board. I started the care board October 1st with Dr. Dave Merman. So I've been here about 14 months now. Ms. Melamed, introduce yourself.
Hi, good morning. My name is Marissa Melamed. I'm the Associate Director for Health Systems Policy with the Green Mountain Care Board.
Ms. Melmed and I will address section 2 in the community engagement work, and we'll take any questions when we're done if that's your prerogative, or we can, whatever you prefer. Act 167 came about after a year's worth of work and effort. It didn't come out of nowhere. The Green Mountain Care Board, legislature, and others saw warning signs of red flags of serious financial deterioration and concern at our hospitals. That was a national trend. It wasn't alone an experience that Vermont had. We saw it nationally in rural hospitals and systems in particular, and we saw it here. We also had the Springfield situation, which was a real shock to our system, a huge, huge red flag. During this time, we also saw an increase in reliance on commercial rates for hospitals to remain financially solvent. We have some slides later today during our hospital section where you'll see the commercial rate increases really start ticking up when the financial troubles come into play. This work, you'll see in the slide, there's a number of steps and reports that were made along the way that ultimately led to Act 167's community engagement work. I would echo what the chair and vice chair said about the significant effort that the state and hospitals and everybody has put into making sure that our hospitals remain financially solvent. Some of those things include extremely large investments by the legislature in this process and by the Green Mountain Care Board in its effort, and AHS, the hospitals, independent providers, primary care, mental health, the whole system has really worked hard to ensure that the hospitals remain financially solvent. Taxpayers have borne a lot of that expense through large rate increases and the money that's been allotted to us, and we have a serious responsibility to use that money well. I would say that one thing we should all be proud of is we've had no closures. Despite the real troubles we've had no hospital closures. And I think that's really a testament to all the work and effort everybody's put into this. So Act 167, the community engagement work, is really a very deep dive into our healthcare system writ large. It all interacts with each other. We've seen problems at hospitals that cause financial struggles that arise from an inability or a challenge to move patients to the right care setting, and for preventative care to be provided before they have to end up in the ED. So some of the financial troubles we have are really not the hospitals doing, but rather the system not being able to support them in full, and vice versa, right? The whole system is interconnected, as we all know. So this engagement work has been a very, very deep dive. We staffed it in a very serious way, and the team has worked exceptionally hard to make sure this process has been thorough and robust. And I think that you'll see that with what Ms. Melamed will present today. So I'll turn it to you to give the details and walk the committee through it.
Great. Thank you so much. You can go to the next slide. In my role at the Green Mountain Care Board, I serve as the project director for the community engagement work of Act 167. So this visual depicts those various work streams that Jen walked us through. All of them in close collaboration with our partners at AHS. And the one that I'm going to provide you some more details on now is the community engagement aspect of that. I'll point you to a link at the bottom. We do have a website as part of the Green Mountain Care Board's page where we provide information updates about what's happened with that project. So we have the link to that for the next slide. So I want to introduce you to the principals that we hired to complete this work. Many of you, if not all of you, have met them already, either through the specific legislative meeting, as well as the series of public meetings that have happened. The effort is being led and facilitated by Dr. Bruce Hamery and Elizabeth Sutherland, both who bring an extensive wealth of expertise, and we hired them very specifically for this. Dr. Hamery has over 50 years of experience in the healthcare industry as a clinician, leader, and facilitator, and in executive leadership roles to support change management efforts through healthcare systems, as well as expertise in rural hospitals. He may be familiar to you as well through his 3 past years of experience in Vermont with COVID, the COVID data modeling project with the Department of Financial Regulation, and the Health Services Wait Time Report. And Dr. Hamery is located in central Massachusetts, so he's not far away, and is planning to be here in person, and will be available to meet. The second principal is Elizabeth Sutherland, who was brought to the Oliver Wyman team for her expertise in examining health disparities and overcoming health equity barriers, specifically her work on health equity zones in Pennsylvania, where she is located. So if you haven't yet, you'll get an opportunity to meet them. Next slide. So this is an overview of the various project phases, which I'm going to talk you through. The first one, which ran from August through October, was engagement plan development. This was a significant aspect of the project. Before we went out into communities and did anything, there was a robust planning process where we held many meetings with legislators, with community organizations, in order to figure out how to do this plan and how to do it really well. And the best way to promote the meetings, how to outreach to people, that are more difficult to reach, how to place advertisements and promote in an efficient way, and gain earned media and other publicity to really promote the project. So this was a careful, well thought out process that we took time with, and we want to thank everyone's participation in that. And it led to a really excellent plan, which went public in October with our first round of public meetings. So these ran from October 24th to November 21st, approximately. I'm going to get you the numbers on how many and participation and for a minute, but they were designed, this first round was held on Zoom and designed to be virtual to get as much participation as possible, make them really accessible. We scheduled them in evenings, which was the recommendation of most people we spoke with, so that people could attend. I'll save some of the details for the next slide. But it happened in a sort of a concentrated, I think it was maybe a 6-week period of time, which generated a lot of publicity and a lot of discussion and activity. And so we were really happy with the amount of visibility that there were in these meetings. So now that brings us to the current stage. This update is coming at a really good time because we've just completed that first round of meetings, and we're now going into a data synthesis and analysis phase. This phase, we are partnered with a second contractor who already works with the board, Mathematical Policy Research, to do any data analysis. This decision was made because we already work with them on a lot of other projects. They're really familiar with our data. We could reduce redundancy of efforts. We could utilize and leverage existing data reports. And they work really well with the Oliver Wyman team. So we are currently working to finalize the analytic plan over the next couple of months to gain the data insights that are needed for the next phase of the plan. And so that's a work in progress. And then we are also concurrently planning for the second round of meetings, which will be communication and discussion of options and recommendations. And that is another round of public meetings. These are scheduled to be in person. The Oliver Wyman team is going to come here during the spring and go to all communities in Vermont to bring these options and recommendations in both to hospitals directly and to the communities directly. And again, we will keep you updated throughout this as these occur, and when scheduling happens, they'll be posted, and we'll make sure that everyone is aware. I think go to the next slide, which is the highlights and gives you some of the details. So we are really pleased with the results of how this first round has gone. So I want to share some of the numbers. First of all, it's comprehensive. We covered the entire state. There were in terms of public meetings, at least 2 meeting types in all 14 HSAs. So those are all the hospital service areas in Vermont. So they went to every community virtually in Vermont to gather these feedback and make sure that we were comprehensive across the state. There were 2 types of public meetings in each region. There were ones that were targeted toward or focused on community members at large. And then there were specific meetings that were targeted for providers specifically, and that's all provider types: physicians, nurses, social workers, EMT, pharmacists, healthcare support staff. There were also many other types of meetings that were held more like interview formats to try to reach harder to reach population or gain specific insights from hospital leadership and boards and state partners. So just to talk about these numbers a little bit, we had over 1,800 participants across all the stakeholder types of meetings. So those are the public meetings where we gathered input. And there were an average of 52 participants at those community-specific meetings. And we outreached or contacted over 100 organizations who helped us either spread the word or gave us their own insights or advice or things about how to help hold these meetings and run them well. And then the table on the right, the top line, which is a slightly different color there, those are the specific meetings that were held just on the engagement plan. So for the planning process, we held 16 meetings with 91 participants, many of them sitting in this room. So we thank everybody for their participation there to help us with the planning process. And then the rest of the columns there are just a way to categorize the types of organizations and people that we outreached to instead of giving you a whole big laundry list. So there were hospital leadership and boards. There were separate meetings with hospital leadership and also with their boards to gain feedback from them directly. There were 28 meetings in total and 235 participants in those. Diverse populations. I want to talk about how we did this a little bit. The original list of organizations that we contacted was created using populations served by organizations receiving health equity grants through the Vermont Department of Health. So that's where we started. And then the list was built out with community input, both on populations to connect with and organizations to outreach. So just some examples of the organizations there. We worked with Vermont Language Justice Project, Association of Africans Living in Vermont, Bridges to Health, Pride Center of Vermont, Vermont Developmental Disabilities Council, National Alliance on Mental Illness, Vermont Migrant Justice, just to name a few. So we want to thank all those organizations. There were 13 meetings and 96 participants. State partners included the Agency of Human Services, Vermont Department of Health, Department of Mental Health, the Vermont Emergency Management Services Offices, Vermont Office of Rural Health, as well, of course, specifically our partners at Agency of Human Services Central Office. We work closely with Pat Jones and Monica Ogilvy on collaboration on this project. So there was 12 meetings with state partners, 18 participants. Community leaders there, that includes other organizations like Vermont NEA, VSEA, Vermont Federation of Nurses and Health Professionals, Vermont Developmental, we named them already, the Disabilities Council, the Vermont Business Roundtable. And so those, there were 3 separate meetings there, 6 participants from those groups. Then the community and provider meetings, those are the public meetings that I already spoke about. There were 18 community meetings with 931 participants and 14 provider meetings with 460 participants. Okay, so the 14 is the 14 HSAs, and then there were 4 statewide meetings that we held just to have additional times that we scheduled at 9:30 in the morning and 11:30, so people could opt to participate at different times if they wanted. And then finally, that last group there, provider interviews and sessions, that included all other provider organizations, again, many who are here in this room: Vermont Association for Hospitals and Health Systems, Vermont Medical Society, Vermont Care Partners, One Care Vermont, Bi-State Primary Care Association, the VNAs of Vermont, and Vital. And there were 15 meetings in that group and 128 participants. So we are very proud of the results and the work that Oliver Wyman did. All of those public meetings were facilitated by Bruce Hamery and Elizabeth Sutherland with support from their staff. They facilitated and led each and every one of those meetings, sometimes 2, 3, or more a day. As well, they were staffed and listened to by staff from the Green Mountain Care Board. All 5 of the board members attended at various times to listen to meetings, as well as any of the stakeholders who participated to listen in on those insights.
I believe the healthcare advocate attended every single one as well.
Yes. Thank you.
We're at every one I was at.
A huge effort, really, for the anyone that I've ever worked with in the healthcare system in Vermont have participated and put input into this, and we're very happy with the results and excited about moving into the next phase, which will come in the spring. So I can go, the next slide here. So they just finished, as we said, as in last week. So we don't have really results to share with you at this time for this update, but there's some key themes that emerge from the round 1, which are listed here. They will be familiar to people, but issues around hospital and provider operations, coordination between organizations, transportation and infrastructure, workforce, financials, patient-centered care, and healthcare services. These are the things that I'll organize them into for us. Also important to say that community members and providers reported both challenges and bright spots within these key themes. So it's not all doom and gloom. There's also, here are some things that are working really well in some communities specifically. Could we bring those elsewhere? Could we scale those up? So that's also really important to say. And then on the other side here, just for next steps, so the Oliver Wyman team is currently synthesizing round 1 feedback. Both the qualitative and quantitative data will inform the round 2 conversations about options and recommendations. This is small. It's their Gantt chart. You're not meant to be able to read every line.
Really squinted.
Don't worry about it. But it's to show that we're in this phase, this data analysis phase, and then they are going to pull their insights together and come back. We are hoping that everything will be ready to go to start scheduling the second round of meetings in March, which again will be with both hospitals specifically and community meetings. And what I think is really important to understand here is that they are bringing the insights, options, and recommendations back to the communities to discuss them. This is not do this in your community. We're telling you that this is what you need to do. It's here are some things. It's really providing assistance to the communities for some options for what what change could look like to support sustainability for healthcare services in those communities. So those are going to be really important conversations. And then when those are complete, the Oliver Wyman team will compile a report that they will deliver to the Green Mountain Care Board around their findings. And that concludes my remarks.
I would highlight just 2 things because they are a little bit difficult to see. But the socializing and vetting of the recommendations with stakeholders is here, and it's really slated for March through May. And then after that, the work on developing and delivering the report and recommendations would be also March through June, although this could extend out quite a ways. And this is an ambitious target. All of these targets have been very ambitious. They're ambitious by design in the legislation, and they're still ambitious. So far, we've been able to deliver on the ambitious goals, but we're hopeful we can continue to do so, but these things are sometimes iterative, and this kind of analysis and tying it together with the qualitative and quantitative components can move as more things are needed and socialized and worked through. So that's where we are.
Thank you. That's a terrific introduction to the work that you've done. Really, thank you very much for the work that you have done. This is terrific. We look forward to the next steps, the recommendations, and we will come back to this during the session at some point. And I'm going to just keep us moving. So unless there's a question of understanding here. Okay, so we're good. We can jump into the next topic.
Thank you, Marissa.
This is a little less controversial. That was a joke.
Yeah, I was just gonna say, really?
Ms. Farabee, if you'd like to just introduce yourself.
So I'm the Director of Health Systems Finance at the board. I rejoined the board about 2 months ago. I was taking a hiatus to get my doctoral studies started in health policy, and I couldn't get enough, so I came back. We have some need to talk to you today.
Oh, welcome back.
A glutton for punishment.
Yeah.
Ms. Barabee was a star employee of ours before she had left, and as many of you know, Director Lindberg left us, I think it was August or September 15th for a position, and Ms. Barabee stepped in prior to her leaving for kind of a seamless transition right in the middle of hospital budgets. So we will update the committee today on the hospital budget process. Part of Act 167 was an effort for us at the Care Board to look at how we review hospital budgets and try to improve that process as much as possible. We owe a huge debt of gratitude to Director Lindberg for the work she did. You'll see how we redesigned some of our work and some of the abilities it gave us. And I think it really was received broadly quite well. A number of hospitals were really pleased with the more granular approach and the more data-driven approach. Of course, in any regulatory process, not everyone loves the outcomes, but that's a target that's difficult to shoot for. But I think the process was really, really strong here. We're going to do a couple of things today. We'll go through a little bit of high-level data and information just to kind of level set where we are as a state, because I think a number of those things influence our decision-making in the regulatory realm and highlight for us where we can improve our process. It also helps understand the context of Act 167 and some of the financial challenges we have that are feeding the community engagement and, of course, the AHEAD and global budget model work. So we'll provide a little of that. I have one large caveat before doing so, which is there's a lot of data, and healthcare data can be read in many, many different ways. We have data experts, and they will tell you that the best way to think about healthcare data is it's often not black and white. What I do personally as one board member is I look at it over time, temporally, and I also look at it in relative nature to other states or other factors, and also triangulate it. Is all the data going in one direction? Is all the data going in another direction? That gives you a greater degree of confidence in the data that you're looking at. So we will provide data, but I want everyone to recognize that that's an important thing to keep in mind as you look at these things. It's just not black and white. So I'll go through a couple slides early that just sort of, I think people mostly know, but are important to keep in mind. The United States spends a lot of money on healthcare. We are one of the largest spenders in the world on healthcare. If you look at this graph, you can see that compared to other well-developed countries, we are far and away the largest spender. Compared to comparable country averages, we're about double. So very high spending in the United States. We also have pretty good healthcare here, which is something to be proud of. Go to the next slide. Within that context, the United States being extremely high on spending on the world stage, Vermont is extremely high healthcare spending on the national stage. And this graph shows you Vermont's healthcare spending per capita over time. And you can see the top line here, the yellow is Vermont, and the orange is the United States. And Vermont used to be below national average in the 90s on healthcare spending and crossed over around 2000 and since then has really diverged quite a bit from national trends. That's not a good thing or a bad thing. It could be a really, really good thing because we have a very healthy population. We spend money and we care about it. We don't necessarily want to be like other states on healthcare spending. So, but it is important to keep in mind this context because we did have good health outcomes before we spent more than the nation, and now we also still continuously have pretty good health outcomes. But the divergence is notable in the graph and how we're using our resources on healthcare. Nationally, hospital spending makes up about 31.1% of total healthcare spending in the United States. It's about a third. Keep in mind, every hospital in every state's hospital system is quite a bit different. Some hospitals might have primary care, some might not. Some might be owned by an FQHC, right? Some might have long-term care. There's all kinds of different things. So it's not just hospital spending. There can be a lot of other things in that number. In Vermont, we spend about 47% of our healthcare dollars on hospital spending, which is higher, but our hospital system is quite robust. We have 14 hospitals in our state, and that's a luxury and a great thing for our communities to have. And we've put in a big financial commitment to have it. So you can see that we are quite a bit higher than the national average in terms of our hospital spending. I alluded to this earlier, but this is a chart of the healthcare system, really a bit rudimentary. But the point here is that it is all interconnected, and we're seeing some of the difficulties in our state, in our hospital system, and elsewhere in the connections and the ability for everyone to transport patients, move patients, and utilize the preventative care that we all believe will help drive down costs. And any fracture or negative to any component of the system hurts the rest of the system, right? So if you think about the UVM Medical Center, it is our academic medical center. It is our tertiary care center. It's where we treat the most serious patients that we have in the state. If they are struggling, other places have a difficult time moving those patients there. That's not good for the system. Likewise, primary care, preventative care is incredibly important to any hospital and to UVM as well. These players are all really, really different, have very different needs, but they all need each other. If you look here, for example, we have problems in the ED across the state with patients going straight to the ED and being backed up in the ED. There's many causes for that and many reasons for that, but two primary ones are the difficulty that we have with preventative care and primary care. People are going straight to the ED and it's backing up there because we don't have sufficient primary care and preventative care up front. Second, the hospitals are under incredible financial strain because they cannot discharge those patients to long-term care or mental health care or wherever else they need to go. So some of these financial problems are backing up here, in part because the rest of the system is also under strain. So it's all very, very, very interconnected, and that's really important to keep in mind. One of the things we've been focusing on, the Care Board, is an effort to really think about the system as we do our regulatory processes. How do our decisions impact the rest of the healthcare system? Are we putting money at the symptom or at the cause? And how do you get money to where it needs to be? Because in my view, it's an allocation challenge. There is only so much money in healthcare. There's only so much money in the state. So we need to be very mindful of how we spend it to make sure that it's utilized in the most efficient and productive way possible. An incredibly immense and difficult challenge. This is a slide from I believe it's a 2020 slide with 2019 data, so it is dated. But this gives you a sense of where Vermont's primary care spend is. One of the things people look up at and consider is how much money are we spending in different sectors of the healthcare system. So primary care, an incredibly, incredibly important component of our system. There's two definitions. You can define these things any different way, but the two primary ones are a narrow one and a broad one. Under either, according to this report, Vermont is lagging in how much money it's spending on primary care. Under the narrow definition, we're at 3.82% of our spend, which is the 7th lowest in the United States. So we spend some of the most money in the United States on healthcare, but very, very little to primary care. That's a problem. Even under the broad definition, we're under 8%, and that's still around 31st in the nation in primary care spend. So we spend, I think, in the top 7 or so states nationwide on healthcare spending, and yet our primary care is really low. So that's something that we should all be cognizant about and thinking about as we engage in these very significant efforts in healthcare reform. I don't have good data on it, but my hunch and the anecdotes we've heard and experienced is that those numbers are probably getting worse in Vermont. Primary care is immensely, immensely challenged in this state. I believe that we will see lower numbers in the future, and we need to address that now. I'll turn to Ms. Barabee.
Great. So now I'll talk more about kind of the hospital-specific context and kind of national and local trends and hospital. So as we all know, 2022 was actually one of the worst years for hospitals. I think it's about when the one-time funding kind of dried up and utilization was still kind of not quite where it was in all cases. It was a real challenge for many hospitals, particularly small rural hospitals, to keep going. 2023, however, is looking a lot better. I mean, there's certainly variation across hospital types, but margins on a national level are looking kind of much healthier, even regionally in New England. And we'll see later that in Vermont, things are looking better for most. Next slide. So as I mentioned, kind of rural hospitals have been struggling. I'm sure you've seen this slide a number of times, but in 2022 and 2023, those closures kind of continued and are a real challenge. There continue to be increasing numbers of small rural hospitals kind of under threat of closure. And it's something to think about.
What does converted mean?
I'm sorry, converted. So converted means it's no longer a hospital, but there may be some services. Yes. And I would encourage you to go to this website and explore. There are a lot of different ways of cutting the data to see kind of who's being affected by this. So at the same time, as Chair Foster mentioned, Vermont ranks one of the best states for healthcare when you look at our mortality, some of our outcomes, and based on some access measures, we look quite good. We have really great insurance coverage. We have one of the lowest insurance rates, and the number of clinical staff per resident is actually quite high. So if we go to the next slide, at the same time, we do have wait times challenges. And there's a robust report that was done, as you all are aware of, on some of these challenges, so I won't dwell there. We go next slide. And many at the same time also remain underinsured. So despite having coverage, it's quite difficult to get the services that you need at a price you can afford when you need them, and so that is a real challenge. At the same time, our premiums are much higher than the national average for commercial insurance and are growing faster. And
Can you back 1 second?
yeah.
So one data point I would add in just for context on this slide. This is the qualified health plans nationwide versus Vermont. Nationwide is yellow, Vermont is the top. It's not entirely apples to apples. As I said, healthcare data can be tricky. And the difference here, some of it can be attributed to a couple of things. The starting point. One is that we have more robust insurance in Vermont. The legislature has mandated that our insurance products are better and have more for our people. And that was, in my view, a wise policy choice. So some of the differential that you see in the starting in 2019, I think is certainly attributed to that. How much of it, I can't say, but certainly some of it. However, I think, again, speaking temporally, if you look at this slide, I think that's more relevant here, which is we've grown really, really fast. By my rough calculation, I think we've grown about 58% on our qualified healthcare plan expenses, while the national average is more around 3.5%. And this is just the qualified health plans, not insurance writ large.
So if we go to the next slide. So if you look at, so this extends to the employer-sponsored insurance as well. And so employers are disproportionately kind of shouldering the burden. So while we're not passing on, you are seeing increased premiums and out-of-pocket costs for families, but employers are really feeling the burden here. So we can go to the next slide. It's not that we're consuming more hospital services per capita than other states. So we're actually very low. So this looks at hospital admissions per 1,000 residents by state, and you'll see the green bar on the left is Vermont. The yellow bar is the United States average, and so our admissions per capita are quite low. But what you see is that the costs and the growth of expenses per inpatient day, so those who are utilizing inpatient services, and of course, this is just a very narrow look, it is growing quite quickly, and we kind of eclipsed the national growth rate here.
Can I ask a question on slide 25? You've got three different
lines. Oh, I'm sorry. So the top line is the total annual premium. The middle line is the employer contribution, and the bottom line is the employee contribution. The yellow lines in each of those cases is the United States, and the orange is Vermont.
Thank you.
So if you look here, so the import of this, which I think is that the employer contribution, the top, Vermont was steady with national average and then started moving up more recently, and now we're quite a bit higher. However, at the same time, the employee contribution has been flat and steady pretty much with, so the employees are not paying more, but the employers are. There is a concern that will start to shift. Employers have limited resources, and if the economy turns, it gets even harder to make those contributions. And certainly
that'll be an interesting conversation, especially given what the economic situation may be for income overall.
Exactly.
And what you're able to purchase for that amount is often kind of decreased.
Some employers do start shifting more as their costs go up. Concern.
Thank you for the clarity on that.
Yeah. And probably feel free if I'm going too fast. So, to kind of get into the weeds on where we are in Vermont. So this is, non-audit actuals we just received for most of our hospitals. Otherwise, we created an estimate based on year-to-date numbers we received through the hospital budget process this year. So you'll notice on the left, so 2019, the blue bar is representing the net patient revenue and fixed prospective payments. So it's all the patient service revenue that a hospital receives for providing services. And that has grown in 2023. And then you can see the bars over time kind of decreasing in 2022 and increasing in 23. This is the operating margin. So we've gone from a negative almost 2% operating margin back up to a 1.5% operating margin approximately in 23. And, we still need to go through, and they need to audit their financials, and they'll submit their final in January. And we're still waiting on one hospital. So these are very fresh data, but I wanted to be responsive to the request.
And just to clarify that 2.77.
Oh, yes, 2021.
Federal
yes.
infusion of dollars.
There was a lot of, yes.
Correct. And so the drop off in 22 is largely the omission of those.
Okay.
And then I would say in 23, a lot of it is, I think hospitals have improved some of their operations. And I think we've seen, the very large rate increases that we had for fiscal year 23, I think is also showing up here, which has put the hospitals in a system-wide, a much more stable financial footing.
Mm-hmm.
Thank you.
Yes. And so as Chair Foster mentioned, the board has been looking at its processes and kind of adopting a continuous improvement framework, and how can we make this process work better and be more transparent and predictable. So the goals kind of that we set out were to establish objective financial metrics for hospitals' financial health, improve evaluation of hospital performance on financial as well as non-financial measures such as quality, access, efficiency, and productivity. And then alignment across the Green Mountain Care Board's regulatory processes, so between hospital budgets, rate review, ACO regulation, et cetera. And then increasing, as I mentioned, the consistency and predictability of the regulatory process so that our regulated entities can understand what to expect and prepare accordingly. And then to minimize the administrative burden where appropriate. We don't want to collect data that we don't need or ask anyone to jump through hoops for no value add. So we've spent a lot of time to go back and reevaluate what we're working on. Okay. So in the 24 process, most of this work that Sarah Lindberg, Director Lindberg, really advanced was to refocus on better balancing kind of the hospital sustainability and affordability criteria in the hospital budget process. In that process, the board established a 2-year net patient revenue target of 8.6%. So again, that's the amount that the hospitals will collect from patient services. The 8.6 was this 2-year target based on the APM is all payer model growth target, which was established in order to bring healthcare spending in line with economic growth. We also this year, the board capped hospital commercial rate increases by payer. This was a very different approach. I think historically we've been thinking that the prices would kind of trickle down from the commercial charges, but we know this not to be happening. So they were very clear about the budget orders to ensure that rate increases are not disproportionately attributed to some beneficiary populations over others, and that was a big change this year.
So what that means is you don't want a situation where an out-of-state larger insurance company is using their market power to pay much lower rates. Meanwhile, having Vermont insurers pay more, you want it as an equal cap to everybody as opposed to north and south, depending on other factors.
And we also increased kind of this evidence-based regulation through greater reliance on data and benchmarks. There's a link in the slides to the budget review tool. This was just kind of the start. We're working on a much more fleshed out kind of, dashboards and analytics that can be tracked and followed over time. And but this was a great place to start this year to really look at what peer hospitals and national kind of best practices are doing in terms of hospital prices and utilization, labor. So we see them. So this is kind of an example of that tool, which you can kind of click through, and there's methods descriptions on the last tab. But basically, these are showing you the distribution of hospital performance on a particular metric. For example, adjusted cost per discharge was one, or cash for operations. And so you can see where hospitals fall in this distribution, if you're in the 25th percentile or 80th percentile, relative to our Vermont population, but also sometimes relative to, if it's just critical access hospitals or academic medical centers. So making sure that we're comparing apples to apples. And as Chair Foster mentioned, no single measure is going to tell you the whole story. So it's really important to kind of capture as many different measures, recognizing their limitations and triangulate across them. So that's kind of how we're using this going forward.
And there's also explanations sometimes. Sometimes there'll be aberrant data and there's a reason for it. And so the process is to really inform ourselves as best we can, as thoroughly as we can, and this was in our guidance so that everyone knew kind of what we'd be looking at. And the process was new this year, and we'll have it. This will be the second year coming up, which I think will be great. And as Director Barabee said, it's really isolated by hospital type, so critical access compared to critical access. We're not comparing UVM to Gifford. It's really trying to get as apples to apples as we can, and there creates opportunity for everyone to have conversations around, you're doing really well on this, how are you doing it? And to share that learning. And likewise, it looks like there's an opportunity here. Can you do anything different to get this in line to help us on the affordability side? And that's what we think this data helps us understand.
So the 2024 hospital budget requests came in. So this first column is the NPR plus the fixed expected payment, so the patient service revenue growth. So the 2-year growth. So you'll notice compared to the 8.6% target that the board set for 2 years, the requests, weighted average request across all hospitals was 19.3%. So that's almost 11 percentage points higher. The commercial price growth, this is a 1-year price growth request, was 9.84%, and operating expense growth, which is kind of an assumption in the model, was around 5.71%. So you can go to the next slide. And so I think the board really tried, given the hospital sustainability challenges and the work underway, tried to, balance this affordability challenge. So this slide is showing kind of what the requests were relative to inflation, hospital inflation, Medicare market basket, and also the median household income growth in Vermont. And so what you can see is that these requests are really quite high compared to what the rest of our system and our economy can really afford. And so striking that balance given the precarious financial situation of hospitals was a real challenge this year, as it has been in recent years. So we can go to the next slide. And so this is kind of showing again, kind of how this shows up in our other regulatory processes. So, you know, real increases in hospital spending and hospital prices have real implications for the rates and the premiums that are kind of passed down through the system. And we see that in our QHP rate process.
Just to take a second on that, this is again in the QHPs and how much money was added each year, year over year cumulatively. So over this 6-year period, it's $127 million on MVP and $152 million on Blue Cross, or $280 million on the Vermont individual and small group plans. That's how much more those plans pay. Keep in mind there are subsidies for the individual market available to some people and not on the small group. They may sunset. We hope they don't. And again, as to what goes into this, it's a lot more than the hospitals. It's all of our system. It's pharmaceuticals. It's utilization. It's how sick our people are. It's primary. It's everything. So it's that's where that's coming from.
And the next slide shows that in a cumulative average rate growth. So you'll see that MVP over 2019 to 24 in the individual market was around 80.4% cumulative growth. Blue Cross Blue Shield, you have 64, almost 65% cumulative growth.
Was there a similar metric from the board for the hospital? It was 8.6. Is there a similar metric here?
This is a great question. We are developing that right now so we can get a better idea, and I think it's also important to understand where we're starting. So having kind of magnitude of, you know, relative prices, but also how that has grown over time. Yes. And I think it's important to recognize that this is national news as well, but the national concern is really about a 6.5% increase to employer plans, and we're really kind of well beyond that here. So, you know, while it is a crisis nationally, we are kind of on the end of that spectrum.
So for comparison's sake, our QHPs the last 2 years were both deep into the double digits. I think this last year, one of them was around 14%, another was around 12%, and I think the year prior it was kind of a similar magnitude. So again, looking nationally, if it's nationally it's 6.5 and there's a Wall Street Journal level of concern about it nationally, we need to look really hard at how we're using our money and what's going into us having 12, 13, 14%, how we can best address it.
And this is again showing kind of the Vermont specific view on annual premiums for a family of 4 and out-of-pocket costs and how that has increased.
And that is just the QHPs.
Yes. So this is where we landed this year. So the board created, adjusted 7 hospital budgets on the commercial rates, and that accumulated to $145 million, around 7% to 8%. If you go to the next slide, but largely left the net patient revenue untouched. And so because net patient revenue is prices times how many services you use, largely, if you're still on fee for service, there's certainly that fixed prospective payment component, which.
Go back one.
Yeah.
We go back one. So this, we'll walk you through it briefly. This is a fiscal year 23 approved rate increase. So how much more money is being paid by commercial insureds for a service, right? So they paid 100, now it's a 10% increase, it's 110, right? That's what this is showing. This isn't how much the QHPs or anyone else is paying more, it's just how much more the hospitals can receive. So in 23, you can see the rates of approval are really high. 12%, 12.2, 10, 17. And then you can see the 24 submitted. That was what was requested this year. And you can see the 24 approved. If we look at this system-wide, submitted was 10.6%, and the board approved a 4.1% increase across the system. And that translated to $145 million of savings on the cost. And here in this column, you can see what the hospitals requested over a 2-year period, because of the 2-year guidance, remember? System-wide is a 21.1% request for increased payment for each service. And system-wide, we approved 14.6%. The big bolus of that, most of that money was in fiscal year 23. And it was really because of the sustainability challenges. And then this year, looking at a 2-year period, it was more right-sized to reflect that there had been a huge increase in the prior year and that creates financial challenges. And financial challenges are important because they do have an impact on our local economies. As businesses devote more money to healthcare, that's a challenge. But I think more fundamentally, there's equity issues in that people have, with less money, bear the brunt of this a lot more, and that creates a real equity concern. And second, there is a correlation to high expenses causing people to delay care or avoid care, which also makes it more expensive when they get there. And so this reflected that. I would also note that the inflation from that earlier slide was, I think 7.1 was the amount of inflation, around there, 7 to 8%. So if you're trying to keep those things somewhat in line over this last year, 4.1 was higher than inflation for 1 year. So every hospital on average got above an inflationary increase this year. And over 2 years, I think it was nearly every hospital got more than double the 2-year inflationary amount. And that's really a reflection of the challenges that we have, but trying to just balance those things, which everyone recognizes is exceedingly difficult.
I was going to ask this at the end, but I'll ask it now because you keep talking about inflation. And how are you taking into account, on one of your slides, I think it was slide 31, you were talking about keeping it within economic growth and inflation. So how are you accommodating medical inflation, inflationary costs as compared with the rest of us?
Yeah, so these measures, I forget which slide it was. There are 3 different measures that we were looking at. Household income growth, right? And then Medicare market basket, which is a measure of services that Medicare pays for, and nationwide, how much those are going up. So these are the Medicare market baskets, a measure of hospital cost inflation. And then you have hospital PPI, which is another metric that's generally used to measure that. So those are what we looked at.
Thank you.
Can catch back up.
You have a question on that one?
Senator
Kitchell.
Oh, Senator Kitchell.
Thank you. I have one question. We know that I'm just wondering to what extent, if we were to adjust for demographics, this would change our relationship to the national trends. New England as a region is aging, and other states are not as much. And the other factor here is that aging population comes with Medicare as its payer, and Vermont has been disproportionately disadvantaged by the level of Medicare payment for hospitals for decades relative to other states. So I realize I'm just trying to ask whether the extent to which these comparisons might be somewhat different if we looked at maybe New England, simply because that shared demographic reality of an aging population, and usually that population requires more healthcare services. So that's my question. And the other, I understand there are 2 hospitals that are appealing your decisions relative to the budget process. Is that, if you could confirm that?
Yeah, I can start if you want.
Sure. Yeah.
So a great question, Senator Kitchell. On the first and the demographics of the state, it's nuanced in that you're correct. Medicare pays for our aging population. They're not coming through on the commercial market. We are an older demographic. Most of New England is. And if you look at this data compared to New England states are generally quite a bit higher on spend and insurance increases. So that is an accurate point. We are also generally considered one of the healthiest states in the country. We're generally considered one of the most active states in the country. So our population is quite healthy and our utilization is quite low. So I think those I don't have an exact calculation, but those counterbalance the fact that we are aging, that Medicare pays for that. And it's a very, very healthy Medicare population compared to other states.
Yeah, I'm just thinking though, if the Medicare reimbursement is low, the extent to which that influences what the other payers are having to pony up, so to speak. And I'm going to put in a plug. Vermont's had pretty much universal access for our children since the early 90s. And one would hope that those healthcare investments in prevention and early care are yielding some results as it relates to how we look in terms of health status.
Okay, so thank you, Senator. And what I'm going to suggest is this is the place where we could get into a full-blown discussion.
No, but I just want to bring
you're
up
right. You're absolutely
the Medicare
right.
reimbursement. I think is a big.
It's a huge issue.
A big issue for us, particularly when we're looking at global payments. So I'm just bringing it up as something that historically has been a real force in terms of Vermont healthcare landscape.
Thank you. And I think that we all agree with that 1,000%. We've been consistently underfunded at the federal level. So so that's a message, I guess, but that's something I think we'll come back to going forward, and we're putting a pin on that one.
And my other question is, are there 2 hospitals appealing? Is that correct?
So yes, to respond to the first point, I believe we are the lowest cost Medicare state in the country. And I do think that I think that's a fair point. And on the appeals, yes, there have been 2 appeals noticed. Both, I haven't read the papers that closely, and there's more papers coming in, but 2 hospitals, I think both of which were approved as submitted. And if my memory is correct, the focus of the appeal is on a standard condition applied to all hospitals relating to whether or not the cap applies to all payers, is my understanding.
Thank you.
And the Medicare reimbursement is data that we asked for this year and didn't kind of have that full picture. So it's something we intend to collect going forward by year to get that understanding of just how much we are being underpaid and in what payer group and how much that matters for the budget. But we weren't able to get into the details of that this year. So this slide shows historically what has been approved for patient service revenue over time in terms of the proportion of the request. And you'll notice at the bottom that it's around 99 to 100%. So of the total revenue that was requested through the budget process, most of that revenue was kind of stamped to go forward. Yes.
Sorry. Some people have asked, so it might be on people's mind, why did we do that? And so we have approved historically the entirety of the budgets, pretty much 99%, really across the board for every single hospital. The concern that hospitals sometimes will have is that the rate increase that we talked about earlier wasn't approved at the same level. So the budget was approved, but not the entirety of the rate. And this year, the entirety of the rate was, I think, lower than previous years. And I can share one board member's perspective, mine, on why I thought that was the right thing to do. And part of that is the access problems that we have in the state. And so this allows hospitals to hit their budget and meet their budget to the best of their ability by improving some of the access challenges we have. So we're not paying significantly more. We're making it up more for on volume and getting patients in the door. So that was some of my thinking on that. Sorry, Ms. Pratt.
No, please. Okay, so we can keep going. And so this is so the board hasn't approved guidance yet for 25, but wanted to give you kind of a preliminary view of what the staff have been thinking about. So this approval without modification, so setting benchmarks for the net patient service revenue as we've done in the past, but also setting kind of a benchmark in anticipation of the budget for commercial price growth. And over time, what is the right amount of commercial price that we should have in our system that Vermonters can afford? And we're probably not going to get somewhere overnight. There's huge variation across hospitals in terms of how commercial payers are affected, but it's something that we will be looking at and thinking about in more detail. Another benchmark that staff are thinking about proposing is operating efficiency, and maybe there's a series of metrics there that will help us understand some of the challenges that hospitals are facing and kind of helping them set targets over time for improving that. We are also thinking about how to continue to evolve our process to be more patient-centered by incorporating more robust understanding of communities' access, quality, and affordability of care. So as we mentioned, we've made some progress on affordability, but access and quality are two areas that we're kind of hoping to kind of extend some of our analytic capabilities. And then to continue to improve the data collection, analytic processes, standardizing and automating, having more dashboards and kind of data at our fingertips, and making that publicly available so people can follow kind of how our health system is changing over time. And then, as you heard, Act 167 is well underway, and there will be insights and recommendations that will be kind of presented to communities and the public later this spring and summer. But I think the final recommendations won't be delivered until kind of right before the budget process. So we wouldn't anticipate seeing any real changes proposed in those budgets, but it might be an opportunity for hospitals to kind of comment on kind of what insights they glean from that process. And but I think that will be a multi-year.
Okay. Questions, and we got one more slide.
Well, we just paused here. It's just your language on the hospital budget. So there'll certainly be, depending on where the state lands, evolution in terms of how our hospital budget process may respond to those changes.
Well, it will be exciting to hear about what decisions are being made around global payments and how that works. And what's the timing on maybe establishing a metric, or how to establish a metric, I guess is more like.
For global budgets?
Yeah.
I think we would like to wait to speak to that during the ahead discussion, if that makes sense.
Sure, we can do that.
Okay.
That's fine. And I know that's coming up. The other area that you mentioned that's really important is quality metric analysis, and where that is, because we've been talking about that now for several years, and how that influences budget decisions and what we're doing to accumulate data that allows for clinical analysis. And so we'll be asking for an update on that, either jointly or separately in our committees going forward. And I'm sure we'll hear more about that today from AHS.
I have a quick question.
Go ahead.
So I'm really intrigued on slide 24 when you showed the qualified health plans, how ours are so much higher. And, in this building, those are the plans that we really impact. We can't impact self-insured, can't impact Medicare, we do impact Medicaid. Will you be doing any more analysis around this, or have you dug into this at all?
The answer, you're exactly right. And same with us, we have limited impact, right? We can't impact Medicaid rates, we can't impact Medicare rates or the independent markets.
Right.
So this is where we make our decisions, and we are drilling down more as to what all the factors are that are going into it that makes Vermont so much higher. I can give you some high level views, and some of it is that we have a lot of resources available to us here, and they're costly. And some of it could be also our population. Some of it could be the services that we're providing in our insurance market. All those things can be factors.
Great, thank you.
Any other questions for clarification? This is good, and you can, I think, maybe you can't, but I sense that there's a lot of conversation that we'd each like to bring up, and so this is the beginning of a longer process. Look at
Just the beginning.
feeling the reins. Tug. So thank you very much. This has been extremely helpful. Thank you, really. And the data is very helpful. And we're going to shift over, I think, at this point to the agency, and because we're just a little bit behind, we want to catch up.
Thank you.
But I hope that you will be able to stay for the rest of the meeting into the afternoon.
Yes.
We're planning to, and thank you for inviting us.
Terrific. So Wendy and Pat. Any more chairs in this room? It's called musical chairs.
Evidently, they thought Coyotes was going to be more
Coyotes are,
next door.
actually, today is PUC.
Oh, PUC.
And I'm not over there, yeah.
Yeah. That's been a big deal. Yeah.
How are we doing, okay?
Let's see if we can get the screen sharing going.
Yay.
Wendy, I'm impressed.
I'm always impressed when it works.
Great. Thank you all for having us here today to give you an update on what is, needless to say, a big body of work that's happening right now. For the record, my name is Pat Jones. I'm currently serving as interim director of healthcare reform for the Agency of Human Services. Wendy?
And for the record, my name is Wendy Trockton. I'm the Deputy Director of Healthcare Reform within the Agency of Human Services. Thank you so much for having us here
And
today.
you're pretty much looking at the healthcare reform team, right? You're getting the whole group at this point.
So why don't you just go right ahead with your presentation? We'll hope to get through the slides.
Yeah, we sort of have a two-parter today. The first part we'll talk about, what we've been doing to develop a proposal for a next all-payer model. And that really relates to the Act 167 language and work that we're doing, I want to say, in close collaboration with the Green Mountain Care Board on that. And then, once we're through that part, we will tell you what we know at this point about the AHEAD model, which is states advancing all-payer health equity approaches of development. I've worked hard to memorize that acronym. Clearly, they made the acronym first and then developed the language to support it. I do want to say that in the middle of that is health equity. So keep that in mind. Clearly, that's an important element, really central element for both the federal government and for us. So I don't know if we might get through the sort of what we've been doing, the pre-proposal to develop the proposal, and we might, before the break, get a little into the AHEAD model, but we'll see how it goes. So next slide. And then the next one after that. I'm going to give you the briefest possible synopsis of our current all-payer model. I think you all have heard about this over the last many years, but want to just sort of level set where we are right now with our current model. So it is an agreement between the state and the federal government, CMS in particular. And that, that's really what these models are. They are a way to ensure Medicare participation in healthcare reform. We've got a lot going on in Vermont in terms of, Medicaid payment and care delivery reform. You all have been essential in that, and I'll call out in particular the Blueprint for Health expansion that you all worked so hard on last session. And you'll see, just a teaser, you will see a lot of that reflected in the federal model, which is very exciting. And commercial payers have the work that they do around, supporting care delivery and the financial aspects. So really what the all-payer models are about is getting Medicare involved. It takes these models for them to be able to pay for health care differently. So the signatories to the current model are the HS Secretary, the Governor, and the Green Mountain Care Board Chair. So three signatories. It is an arrangement that allows Medicare as well as the other payers to pay for healthcare differently. And what our current agreement does is it establishes some accountabilities that the state is responsible for. Those accountabilities to relate to cost growth, so reduction in the rate of growth in healthcare costs, certainly very salient to the information that you just heard from the Green Mountain Care Board. There are population health goals in that model, and it's a pretty ambitious set of population health goals and quality measures, really organized around three key elements: improving access to primary care, reducing deaths from suicide and drug overdose, and reducing the prevalence and morbidity of chronic disease. So those were like the overarching goals, and then beneath those were 22 specific measures that the state agreed to be responsible for. And then, and the measures relate to quality, and there were also accountabilities around scale. How many folks could we get into this alternative payment model? So, in the broadest sense, the idea is to shift from paying for fee-for-service care. So instead of paying for each service, to move to more predictable prospective payments. And, again, those three overarching goals, reducing healthcare costs, and in this case, it's really what we call the triple aim for healthcare. Why do we bother changing payment? The point is to change the way we deliver care, and the point is to change outcomes. So when we talk about the triple aim of healthcare, what we mean is reducing growth in healthcare costs, maintaining or improving quality, and improving the health of Vermonters, which is really the ultimate goal. So as you know, our current model has relied on an accountable care organization. In this case, it's One Care Vermont. The purpose of the ACO was to develop a voluntary network of providers to come together and really work on some of these financial and quality areas. And those providers agreed together to be accountable for the cost of care and quality for the people that they serve. The original performance period of the model, we signed the agreement in 2016. Medicaid actually rolled out a program in 2017 as sort of a precursor to the all-payer model, but the first official performance year was 2018, and it was intended to be a 5-year model. And, the pandemic occurred and many things have happened since 2018. And so CMS asked that there be an extension. So we're currently in the middle of a 2-year extension. The model will go from now through 2024. We do not, at this point, have anything beyond 2024. So it would end at the end of the year. Our performance years are calendar years model. So that's just the highest level overview of what the current model is. So why do we care about keeping Medicare in the model? There's a lot of benefits, and actually some of those were just talked about in terms of us being a low-cost Medicare state and having some pretty notable healthcare reforms that Medicare has participated in that have shown some good results. So, bringing Medicare to the table for our state in these innovative models can really help keep that idea that we are a low-cost Medicare state, and that needs to be considered when they are talking about how to pay for healthcare and how much to pay for healthcare. So that's important. We do have these past reforms. the Blueprint for Health went statewide in about 2011. At that point, Medicare decided to participate. They had a demonstration model called the Multi-Payer Advanced Primary Care Demonstration Project. And so they began paying, and as you know, commercial payers contribute as well. Vermont is now the only state that's still getting funding from Medicare for that type of a program. And our evaluations have shown that it saves money. And so having them at the table continues to recognize that our reforms do that. And like the current all-payer model, which has also been shown to save Medicare dollars, that those are still, front and center in our conversations about how to pay for healthcare. As Senator Kitchell noted, we have an aging population, and Medicare is a big portion of the dollars that go to hospitals in particular, but really across the board. And so having them be part of a model that isn't just, fee for service, here's the rate done, but having a more innovative model can really help us to influence how much and how reimbursement occurs for providers. I mentioned the Blueprint earlier. To quantify that, about, somewhere between $9 and $10 million comes into this state every year through the all-payer model. It goes to the ACO, but that is then distributed to primary care practices to support patient-centered medical home payments, to regions to support community health teams, which are part of the Blueprint that really provide that integration of care and services for people with complex needs. And the support and services at home program, which is a sort of housing-based extra support for Medicare beneficiaries to make sure that they have wellness services, care coordination, and the like. And without these dollars, certainly for the primary care practices and the community health teams, there would still be Medicaid and commercial dollars coming in. But without these dollars, it's hard to imagine how there could be a SACH program, because it's almost wholly reliant on Medicare dollars because it's a program for Medicare beneficiaries. And, that is another program. The Blueprint has been evaluated, the all-payer model has been evaluated, the SASH program has been evaluated, and they have all, from the Medicare point of view, shown cost savings. And, anecdotally out in the field, when you talk to providers, I think, we certainly hear that things like community health teams make a big difference for their ability to care for their patients. The patient-centered medical home payments allow them to potentially hire care coordinators for their practices, and that makes a difference. And then again, the work that you all did last session on the Blueprint expansion to really look at screening for social determinants of health or health-related social needs, integrating mental health and substance use disorder treatment into primary care in a more robust fashion than we've been able to do to date. And it's a Medicaid pilot, it's 2 years, but it promises to make a difference for the practice of primary care. So getting those dollars, it's a decent amount of money. It's not an enormous amount of money, but it makes a big difference. It certainly makes a difference for the SACH program. Another area that we're able to take advantage of when we participate in these models is that Medicare will sometimes waive certain regulations to help improve care delivery. Wendy's our expert on Medicare waivers, and so I'll give an example of one, but if folks have questions later on, we can, give a few more examples. I'll actually give two examples, one in deference to Representative Goldman. The first is that, under current Medicare regulations, when someone is in the hospital, they need to stay there for 3 days if they're a Medicare beneficiary before they can be discharged to a nursing home. And, that may not be needed or practical. There may be rationale for someone to go directly into a skilled nursing facility. So that's one example that is waived. Telehealth is another. But one that we may see in a future model is the ability to provide concurrent curative care, palliative care, hospice care, so that people who are at the end of life or who have life-limiting illness can access services and potentially access them earlier than what they would otherwise. And that's a conversation that we've had with Representative Goldman. So that's exciting as a potential. So those are the types of things that we can see with those flexibilities in Medicare regulations, which can, really make a difference in care delivery. And then finally, and I think we've sort of touched on this and we'll touch on it again, but for particularly providers out in the community and for people who use the healthcare system, when there's a lack of alignment between how care is paid for, how quality is measured, how things need to be reported, two things happen. One is fragmentation occurs, and so there's different sets of incentives, different motivations depending on how things are being paid for. The other thing that happens is that it sends, it causes administrative burden when things are done differently. And it can really, if we can align things, it sends a very strong signal to healthcare partners as to what our priorities are and so forth. So, I'm not going to pretend this is easy. I've worked in the quality space for quite some time. And, a good chunk of my quality measurement and a good chunk of my career has been spent on trying to align, develop quality measure sets that resonate, that align with things like our state health improvement plan, that address the issues that really matter to Vermonters. And then when we're looking at measuring the quality, doing it in the same way. And, people will still say, and they're not wrong, there is a lack of alignment, how you specify a measure, how, this payer wants it measured this way, this payer wants it measured that way. We've made a lot of progress, I think, here in Vermont, but it is not an easy thing to do. The same with payment systems. It's not easy to align operations. We've seen it in our current model. We have a payment model where Medicaid does a prospective payment to the ACO for your hospital and professional services. It is not reconciled back to fee-for-service. Medicare, prospective payment, but they reconcile it back to fee-for-service. And commercial has done a lot of work in this area, but even just getting the operations in place to mechanically pay differently can be, it's huge. It's a big lift. So, there's always work to be done in alignment, but the more we can align in both design and operations, and what we require from folks, providers and others participating in the healthcare system, the better off we are in terms of sending that similar message and reducing administrative burden. So anyway, those are, bringing Medicare to the table as a, needless to say, major payer. Those are some of the benefits from doing that. So in the last year plus, I've been in my role for less than a year, but in the last many months since, Act 167 was passed, our efforts have really been focused on working with CMS, or more specifically, the Center for Medicare and Medicaid Innovation, which is their sort of reform arm, and trying to provide, we knew they were planning to release a new model. We knew that the days of a state-specific model were going away. They had made it clear that what they wanted to do was release a model that would be a multi-state model. And so we've spent quite a bit of time, a lot of time, working with them and trying to articulate the things that we think are important to see in a model that would potentially support Vermont's participation. And I want to, there are so many people in this room who have been part of those discussions. We really, we've had, you'll see in a minute that we've had a work group structure and a number of areas where we have discussed these issues with our partners in the healthcare system. And so in an effort, to really try and reflect those priorities to CMMI, these are some of the things that we have articulated. And they sound very similar to what you just heard from the Green Mountain Care Board. The first is support for rural provider stability and sustainability. As Chair Foster and Elena discussed, things are really fragile nationally and in Vermont in terms of being able to recruit providers. Workforce is a huge issue that we hear about all the time. And I want to again note that Wendy has a lot of expertise in trying to stand up some programs that you all have allowed us to do with appropriations to try and beef up our workforce. Inflation is a concern, as we already mentioned. And just, how do you deliver healthcare in a rural setting? How do you assure access to healthcare? So that's one element that we've tried hard to reinforce. The other is, and it sounds, it kind of goes without saying, but, that predictability in payments. The fact that Medicare has reconciled under the current model back to fee-for-service. So, providers would get these payments, the ACO would get these payments, but they weren't sure that they would get to retain them. That's a problem that reduces predictability. I do want to say though, with that program in place during the pandemic, it prevented a world of pain for a lot of providers. Those providers who were, and not just our hospitals and practices that were getting those predictable payments, but when you look at the work that the Department of Vermont Health Access is doing in alternative payment models. I'll use the designated mental health agencies as an example. They had a predictable payment stream because of work that DEVA had done. And so, those providers who were getting those reliable payment streams during the pandemic, it made just an enormous amount of difference for them. As people stayed home, volume fell off. And people were really afraid to seek care in an in-person setting. Telehealth and those telehealth waivers made a big difference too. So, when we talk to providers, I worked at DEVA's payment reform unit most recently, but when we talk to them about, their interest in payment reform and healthcare reform, it's often around predictability and flexibility in how you can use those dollars. So we talked about this already. It's really important in a subsequent model that we receive the right amount of revenue from Medicare, that there be recognition that we are a low-cost state. If they're talking about cost savings, when you're already one of the lowest cost states or the lowest cost state, trying to achieve further savings may not be realistic. And we actually did see CMMI, their director came to Vermont in September. And she articulated a pretty clear message that, you know, they're looking for budget neutrality, but they're really interested in transformation, care transformation, and they're interested in quality. So there was sort of a mitigation of that, you know, cost savings to more of a budget neutrality lens. I mean, I think they're still looking to see reduction in growth of costs, but there seems to be more of an understanding that not all states are the same, that there might be, for a low-cost state like us, there might be less opportunity. So support for investments in preventive and community care was another area that we heavily reinforced. Our current model has allowed for a bit of that, not you know, not a tremendous amount, but you know, there has been some support for area agencies on aging, for home health agencies, for designated mental health agencies in the current model. There's been some really interesting ways of supporting them and really focusing on the work that they do. And so, you know, we really wanted to see that in the model, and then primary care as well. And again, the Blueprint for Health is sort of our signature program in that arena. And One Care actually has a creative primary care model as well for independent primary care practices that they have, you know, they seem to really support. We have 19 practices in that program, and, you know, that's a good chunk of our independent primary care practices. And it's a creative payment model that's allowed for some innovation. And then, you know, talked about this already, but really trying to make sure that those payment models and quality measures are aligned. And then, you know, something we've reinforced heavily is that let this model, if you're selected, feel it's good for Vermont, if we end up moving forward with it, please let it allow us to move forward on some of our really important healthcare reform efforts. And I'm going to just say, and we'll talk about it later, but I'd say there's some mixed results there. I'd say a lot of pretty good news in terms of how they've designed this. There's a couple areas where we wish there had been more, and we'll see if there's some flexibility for us to try and get there. And, you know, I think over time they would get there, but it was just too much too soon. Vermont is in a very different place than a lot of other states in terms of having an advanced primary care model, in terms of having this experience with the current model. So, you know, they had to, you know, because they want a multi-state model, they had to really try and build something that they felt could work for multiple states. So that's the feedback we've given. And again, couldn't have done it without the various partners that have been at the table for the last many months. So our new model, as I said, states advancing all payer health equity approaches and development. We'll not say those words again during this presentation, but we'll call it the AHEAD model. And so, you know, what we know at this point is that They, again, are offering only multi-state models. There will not be state-specific models. Right now, Maryland, Vermont, and Pennsylvania have state-specific models, and those will presumably go away. They are going to award, they're going to award participation to up to 8 states. They're not looking for all 50 states, all comers. They will limit it to 8 states for this model. And we see that in some of their other models too, where it's not across the board. They, on November 16th, they released what is called a Notice of Funding Opportunity, otherwise known as a NOFO. And it's 127 pages long, and it lays out it has a bit more detail than what we had heard prior to that. And it really lays out what states need to do in order to apply for the model. The applications and I'll show a graphic later, but the applications are due, there's 3 cohorts of states. There's cohort 1, 2, and 3. And 1 and 2, the applications would be due on March 18th of 2024. So they're giving about 120 days to respond. The difference between those 2 cohorts is when the model would start. Cohort 2 would have a longer period. The earliest that, and this would be for cohort 1, the earliest that the model would go into place for any state would be calendar year 2026, so January 1 of 2026. That means, you'll recall that I mentioned a moment ago that our current model ends in 2024. Early on, we had heard that they were shooting for 2025 for this model. Some of us who have been around for a while were like, because our experience is that CMS needs 18 months. If they're going to pay for healthcare differently, they need 18 months to, get clearance, to change their systems. It's a big deal. So when they were saying 2025, it was feeling like that might not happen. And sure enough, they realized that it just wasn't doable. So it's now 2026. So they have indicated to us that what they want to do is talk with us and negotiate a potential extension to the current model that would take us through 2025. And the goal there would be if we are selected as a state, if we're in that cohort 1, if we can come to terms and feel that the model would be good for Vermont, then that would provide a glide path. Otherwise, we're probably looking at Vermont going back to fee-for-service payments for Medicare, which I think most people have real concerns about. It would certainly put that blueprint and SASH funding at jeopardy if there was discontinuity. So that's the proposal. So, this is sort of a simple slide, but I wanted to indicate of the elements that are in Act 167, which after our conversations and work with our provider partners and other partners here and our discussions with CMMI, which are included in the AHEAD model. And really, virtually all of them are. Total cost of care targets at both the statewide and the hospital level are a part of the AHEAD model. Global payment models and in particular hospital global budgets are part of the AHEAD model. There is a clear strategy and in fact resources included to invest in primary care. And that's something new that we don't have that in our current model. So that's very interesting. In terms of mental health and substance use disorder treatment services, there is a focus on integrating services into primary care and other health care. So that's part of the element of the model. And then, as I mentioned before, health equity, screening for health-related social needs, having health equity measurement and evaluation infused throughout the model, identifying where there are disparities in health, having the capacity and data systems to collect information about disparities in health. That's all in this model. As far as home and community-based services.
Pat, just to interrupt very briefly, Representative Lanfear.
I'm sorry, I can wait to the end, but it feels like it'll be a while and I don't want to forget. Underneath the mental health and substance use disorder treatments, what do you maybe know about the possibility of the future payment model, including mental health preventative efforts? Not just the treatment, but preventative efforts to be able to pay.
Yeah, in the federal model, what we've seen so far, I'm going to be honest, it's pretty silent. It talks about the need to integrate those services. It talks about, so there's a lot there around transforming care. And certainly around some of that early screening and sort of navigation to services. Where I think the creativity comes is that there's some funding for care transformation. It tends to go through the hospital global budgets, and I'm sort of giving a preview of the later discussion, but there is some ability for states to design their own payment methodologies for hospital global budgets. And so there might be an opportunity there to get more creative. I'm not going to pretend that they're saying we're giving Medicare dollars to mental health and substance use disorder treatment providers. They're really focused on hospitals and on primary care in this model, but there's some, again, that word flexibility, there's some latitude there that may allow us to do some really creative things around not only mental health and substance use disorder treatment, but that really applies to home and community-based services, to your long-term services and supports, to the subacute services like what Chair Foster was talking about with, people are landing in hospitals, but there are not nursing home beds. There are not we have challenges with mental health capacity, skilled nursing facility capacity, home health capacity. So that's why I put that box there, because that's a goal of this model. They want hospitals to be able to transform care delivery and shift utilization to not just primary care, but to community-based settings as well. And they believe that flexibility and the incentives to, for hospitals could support that, but it's not real overt or clear. They talk about the importance of partnerships between hospitals and other provider types, the importance of integrating some of those services into into primary care. But, I think we need to be creative here if we decide to move forward with this model, if we get selected to move forward.
Thank you.
It's a great question. If you were to ask me, where are the areas that we got a lot in this model, I think, the two areas, that I would say are, they're kind of leaving us on our own are this and sort of the more advanced primary care, like the capitated payments that Lung Care is doing with the independent practices, for example, or our current model exempts primary care practices from having to report to what is called the merit-based incentive payment system, which is a quality reporting system that practices have to report to, and they then can get enhanced payments based on their results. In our current model, they're exempt from that. We're considered an advanced alternative payment model. They don't have to report and they get the enhanced payment. The CMS has indicated that this model doesn't qualify as one of those advanced, not the whole model, but the primary care component, because they're going back to its fee for service for primary care, but there's an enhanced payment. And they're saying it's not an advanced alternative payment model. However, we are still engaged in conversations with them about that, because that was I cannot tell you that we are doing our level best. I don't know where it'll land, but it's been if you were to ask me what were the, and I don't want to speak for others who've been deeply involved in this work, but for me, when I looked at it, and I think the secretary would agree with me, the two areas where I think I wish they had done more are home and community-based services, mental health, that whole area. And then which it feels like we're having to take a step back on primary care a little bit. There's some good things about primary care, but in that particular arena, we're having to step back, and that's disruptive. It's very disruptive for the system. So anyway, okay. So I wanted to spend a little bit of time, and I could spend a lot of time on this, but we'll at least give you an overview on what we've been doing in terms of partner participation. So we have an advisory group structure that we have at AHS, but Green Mountain Care Board has been deeply involved in this work as well. So we have an overarching healthcare reform work group that consists mainly of provider and payer representatives, but it's sort of an overview organization, and we meet once a month and keep them up to date on what's happening with the model, take their feedback and so forth. But then underneath that, we have some very focused groups that are actually doing a lot of the work. And the most active is the Global Budget Technical Advisory Group, and it's got broad representation, including, certainly hospitals, payers. We have the healthcare advocate as part of that group, the Vermont NEA. So it's a broad-based group. It's very active. Robin Lunch is my co-chair and really is much of the brains on this group. And we've met, I think, 13 times and about to meet for the 14th time. And it is technical work, really talking about, and if we are to try to use a state-designed methodology, not every state can do that. They're saying that states that have sort of budget, hospital budget authority, rate setting authority, and that have experience with value-based care, and that's us. The Green Mountain Care Board's work and our experience with the current model. We're a state that can actually propose its own methodology. And so the work of that group has really been to say, if we were to do that, where are some areas that we would want to augment what CMS comes out with. And we haven't seen the detailed specifications of because for states that don't qualify for that, they're going to use the CMS methodology. We haven't seen that yet. The details, we have an idea of the principles. We expect to see it early in the year. But we know what their basic principles are. And so Vermont is really digging into whether we would want to come up with our own methodology, which would then, again, would then potentially allow us some of those flexibilities that might support some of those areas that we wish had more focus in the model. So that's one group. Another led by Wendy is a Medicare waiver technical advisory group that's been meeting to propose potential Medicare waivers to CMS that would support that care delivery. I don't know if you want to say anything about that group.
We have several slides later on in the presentation, so I won't go into much detail here, but we did meet last spring, looked at what are care delivery transformations we would like to see in the next model. And we looked at what are operational challenges that have presented themselves during the current model. What are some of the exciting things that happened related to public health emergency flexibilities? And what are some things happening in other states? And we ended up proposing really 24 waivers that we would be interested in looking at with CMMI. So we're still waiting to see what they're going to offer under this model, but we'll be continuing to advocate for some of those areas of flexibilities for care delivery transformation.
And Representative Lampier, a lot of those waivers could be supportive to our home and community-based service providers. So, at the request of a number of our partners, the Medical Society, Health First, Bi-State Primary Care, we have started a primary care advisory group. That's been really good. We meet at noon times, and we're actually getting a number of primary care providers at those meetings, in addition to representatives of the organization. So really focusing in on what's most important to them. And then we had a payer advisory group that was active again, probably in the spring. And, now that the NOFO is out, we'll likely want to reconvene that group, and that we've had Cigna, DEVA, Blue Cross Blue Shield, and MVP. We've had, they're coming to some of our broader work groups as well, but we've had representation from them there, so we'll probably want to reconvene them. Back in the summer and fall of 2022, we also did some work on short-term provider stability. Again, hearing some of those concerns about, what's happening in the system and where the places where access is a challenge and so forth. We did some more broad overview on global budgets as a precursor to the global budget technical advisory group. And we had a total cost of care subgroup as well, what should be included in total cost of care and so forth. So, lots and lots of action and really trying to get that feedback that then allowed us to provide input to CMS. So, the next slide shows our, sort of in the broadest sense, how we've looked at engagement. Again, that summer 2022 work. And to be specific with short-term stability, we really looked at 4 buckets. Workforce, regulation, and a lot of that's what's happening federally with regulation. Systems flow, and that speaks to some of those access issues and bottlenecks. And then revenue, I think, many of you have been involved in sort of the rate studies that we've tried to do to ensure that particularly our home and community-based providers are getting adequate rates. So that was summer of 2022, along with some of these other groups. In the fall, that's when we really started focusing in on, how can we provide input to CMS about what a model might look like. February, and that's about when I joined, that's when we started those technical groups around the hospital global budgets and the Medicare waivers, and then the payer and primary care groups were added a little bit later. In terms of public engagement or broader engagement, throughout 2023, we have, been going to different forums as Act 167 recommended. So the Dale Advisory Board is one place we've gone. The Mental Health Integration Council and the Green Mountain Care Board has a primary care advisory group, so we've gone there as well. And we have, there are mechanisms on both the Green Mountain Care Board's website and our website for public input. And we we sort of do a joint presentation at least monthly at the Green Mountain Care Board's public board meetings. And then let's just say the invitations are coming fast and furious to talk to a variety of other groups. So I'll get into a little more detail in the next couple slides. With just to put a little more around the Dale work group, that's a 16-member board. It includes advocates, service providers, persons with disabilities, and Vermont Legal Aid. We've been there twice and are actually scheduled to go there again on December 14th. Now that we have more information in the NOFO, there's more to share as well. And then the Mental Health Integration Council, which have been meeting, chaired by Commissioner Levine and Deputy Commissioner Crumph. That's a 27-member council, again, with a wide range of participants. And healthcare reform has participated in that group. And then we presented information in September. It was like a town hall type discussion on healthcare reform and equity. And then the PCAG, the Primary Care Advisory Group, we met with them twice in June and then again in November, and have gotten some really good feedback from that group. We are now meeting weekly with the Healthcare Association Coalition, and you can see the list of folks there. Just really answering questions and really getting feedback on the NOFA, because, we've really moved from trying to influence and provide input on the model. We are now in that proposal development that Act 167 has envisioned. So, I have to say, I don't know that I particularly called out the hospitals, but since, both primary care and the hospitals, but because this is, hospital global budgets are central to this model, VAS, the hospital CEOs, the hospital CFOs, they've been remarkably engaged in this work, and we're trying to provide them as much information as we can, including a straw model and analytics that come from that Hospital Global Budget Technical Advisory Group. So we are in regular and constant communication with them, and also with the physicians, the Medical Society by State and Health First, because the components of the model so clearly address those two sectors of the healthcare system. And then there's just one of, a few examples of other places that have shown interest in the model, but we're getting multiple invitations a week at this point to talk about it. So. Okay. So that's sort of the, that part, the Act 167, how do we get to the proposal, and it might be a good stopping point.
I was just going to say, I think this committee probably would like to stop here, and then we can come back. We had a half an hour scheduled for lunch, and I'm asking you if you think from 1 to 3 is sufficient to cover everything that you have left. And we can
I
come back
like
at
to
1 o'clock.
talk a lot, but 2 hours.
Very good.
So you never know, feel free to cut me off, but.
No, this has been terrific, Pat and Wendy. This has been very good and very informative, so we appreciate it. So what we will do is we'll take our lunch break now. Are there questions before we break of clarification from the committee? And we can carry this over after the next 2 hours of talking.
Yep. I got my water here.
Oh, good. All right. So let's do that. We'll take a break now and we'll come back at 1 o'clock. So thank you. Thanks, everyone.
Thanks, everyone.